Moving any wet things from under them, so conduction, convection, heat loss. You know, we don't want to keep wet, cold things near them. That just perpetuates the heat loss. So you want to position the head to clear the airway. We'll get our baby over here so we can. Right, so you just want to, like, obviously we don't want them hyper or hypo extended, just natural position and clear the airway. Always clear the mouth before the nose. And yeah, you guys have got that done. So a slight extension to the neck, just not far back or far forward. So, and then, so is the baby crying or breathing? So if the baby's crying or breathing, let them do their thing. Provide stimulation, provide warmth, and then circulation. The heart rate just needs to be above 100. If they're crying, I guarantee their heart rate's above 100. Just know that. Like, if they're crying or making any kind of respiratory movement, you can guarantee their heart rate's above 100. So, and if they're not crying or their heart rate is not above 100, positive pressure ventilation. So remember, opening the lungs, ventilating the lungs is the most important thing we do in neonatal resuscitation. So you want to open the airway, positioning the head. So this is stuff you guys already know. Sniffing position, just to align all of the anatomic landmarks in the airway to line up, to flow nicely, just to help not hit any obstacles and just help that natural path of flow be nice and open. So you see correct position, incorrect, and hyperextension and flexion. It is like a little bit like sniffing, like nose to ceiling, you know. So it's a little, their head's usually a little bit further back than like what you'd expect just straight anatomical position to be. But about this position, remember they have like huge backs of their heads too, so you kind of have to push it up a little bit just to get some of that pressure off, because their heads naturally kind of push them forward because they have giant heads. So yeah, so you want to, like, when they come out, when you're drying and stim, wipe off their face just to get any, like, vernix, fluid, anything else that's just kind of left on their face, and to help. So if they have copious secretions and you're going to bag like that, turning them on their side just to help kind of everything flow out, just like on a, you know, any kind of copious secretions, turn them on their side to help that, and then mouth before nose, just because they'll breathe it in if you don't. You know, if you do their nose first, their natural tendency is to suck in and then they aspirate it off. So, and just know that if you are aggressive with suctioning or you are deep suctioning, that it can cause a vagal response. If your kid starts, like, you'll see them turn bright red and then kind of starts to turn blue, just know that if you're too aggressive with it, then that can happen. If that does happen, or if they start to vagal with stimulation, with suctioning, stop suctioning and stimulate to help that.
What does stimulating actually look like on this kid? Like what's your technique for that?
So like you're gonna come out, they're gonna put them in some blankets, right? Let's just do this. Yeah, so like basically you've got this, and a lot of times you're gonna catch this kid, right? It's gonna come out, you're gonna get this kid, we're gonna put this baby in here, and what you're gonna start doing while you're getting to your surface or your location, wherever you're gonna like assess or resuscitate the baby, they plant that cord, and you're just like this. That's literally what you're doing. Wiping their face off, kind of assessing their breathing while you're like wiping their face, and then just like rubbing their back. If they're still not breathing, you can like tap their feet. Like I said, if you're like vigorously rubbing their back, and like you can rub, babies are fragile, but you're not gonna break them. Like rubbing their back like this, like literally this hard, you know. And then just like drying them off and stuff. And if at that point they're not breathing spontaneously, get prepared to ventilate their lungs, because like I said, once they go into secondary apnea, if they don't start breathing on their own, no amount of this is gonna, don't waste your time continuing to stimulate, they're not gonna breathe. So yeah, but like rubbing them, keeping them dry while they're here, you know, clean off their faces, get that blood and fluid and everything off their face, tap their feet, Do not hang them upside down and slap their bottoms. But yeah, rubbing their back extremities, just trying to get them to have that tone, right? Because our questions are like, what's their gestational age? How's their tone? Are they crying? So we want to see if they're flexing in and responding to that stimulation, and if they start to cry.
When you say tone, do you mean like, are they doing the
Basically just flexion. Like, so babies hold the natural anatomic position for babies this, right? They fetal position. Babies hold fetal position. So they will naturally come back. I mean, you've seen a newborn baby, they naturally hold this position, right? They want to be in that position, that's where they've been. So you'll see, if you stimulate them, like if I'm pulling their arm out and I'm stimulating their arm, if they have good tone, they're gonna try to pull their arms back. When you pull their feet down to like rub their legs, they naturally pull their feet back up. So tone as far as that, like some babies, you have a baby come out that's like flat, you know, they're just laying there, it doesn't matter what you do to them, they don't care.
Right.
Bad sign, right? You want them to fight you.
Right.
So just like with kids and stuff, you know, if they're not fighting you, they're probably sick. Yeah. So continue this tactile stimulation. Waste valuable time if they're not breathing. If they don't immediately start breathing or crying, then you can just stop that and go straight to positive pressure ventilation. So we just went over that. So meconium in the fluid should be a red flag to you. You always want to know what like they're already ruptured, or when they're born, you want to know the fluid, what color. If it's bloody, has meconium, if it's just like green or brown tinge stain. If it smells really bad, that's a really big indicator of infection. Like foul smelling fluid, you should be like, all right, like we've got to get this kid on antibiotics, we've got to get moving forward, like that needs to be treated. But meconium staining signifies that the baby's been stressed in utero, right? Like babies pass meconium when they're really stressed out. So if they have any meconium, whether it's when they break the water, meconium stain was already there, or even what we call terminal mech, which is like as the baby's being delivered, they have meconium. Like it's a huge red sign that this baby is like, I've had it, I'm stressed, I need some intervention. So, and it also, if when they break the water, there's already meconium staining, which means the baby has been stressed at some point in utero. It can signify like a hypoxic event that's happened. Something's happened that's really stressed that baby out. Which it takes a lot to like stress out babies in utero, right? They're just floating around in water doing pretty good. Like it takes quite a bit to stress them out. So so for meconium, you just follow the normal steps of resuscitation. So PPB should be initiated if the baby's not breathing and the heart rate's below 100. So here was a change in NRP, which we still see a lot of places like this old school practice. So if you show up somewhere to transport a baby, and they're trying to intubate to get meconium out, that's not NRP anymore. The meconium aspirators, we don't even, we rarely use them. We used to think that getting it out of the trachea and stuff prevented the aspiration in the lungs and further lung disease. What they have found in studies that like all the studies they've done, and like postmortem autopsies and stuff, is like it doesn't do any good. So, and as like counterintuitive as it is to just bag that in, like I mean obviously like clear their airway, but then we don't intubate the trachea to pull out meconium that they could potentially inhale. We just bag it in there. So.
And then you just treat like later on if they get septic or infected or whatever.
Yeah, any baby that's like required resuscitation, like and goes to a NICU, will get like say like guilty until proven innocent in the NICU, right? Like we do septic workups, and because it's hard to really assess, they can't tell us if they feel crappy. They can't, so it's hard to tell if it's like a physiological response or if they have an infection. We start antibiotics for 48 hours to rule out infection on anybody who has any risk factors. We have blood cultures in the CBC and antibiotics for 48 hours. If they basically anybody who has any kind of extensive resuscitation or has any kind of risk factor. So yeah, just dry, stimulate, and bag. So the golden minute mark. So like I said, that first minute is where we really want to be doing like a quick, thorough assessment and kind of making that first 30 seconds to a minute is where we want to be making a game plan moving forward. And it's also the telltale of like, we're not going to waste any more time. We're moving straight on from here. That first minute, like I said, you're usually, even by the time you clamp and get things over, usually 30 seconds in. At that point, if you've been stimulating, that baby's not breathing, we're getting our bag hooked up, we're moving forward really rapidly. Don't give them a lot of chance to, you know, like, oh, we'll give you another minute to start breathing, oh, we'll give you another. And like I said, if heart rates are low, ventilate the lungs, and almost 99.9% of the time, your heart rate will come up. So, yeah, so just avoiding unnecessary delays in ventilation, which, I mean, it's not, no one's intentionally not providing PPV, right? But it's just like, you keep stimulating, hoping that they'll come around. You don't want to move on, you know, to intubating and bagging, so you kind of keep like, if I give them another second, maybe they'll come around. Just go right for it. It's better to have everything set up and ready to go and then not need it than the other way around. So, and then evaluating respiratory standing. So, drying and stimming, obviously that's what we're trying to do. We're trying to stimulate breathing, crying, all of that. Obviously don't shake the baby. You want to be rubbing, like I said, kind of aggressively, but not like jarring them or being aggressive. And if the baby's breathing, then you know your heart rate's above 100, and as long as they continue to breathe on their own, then you can provide minimal support, keep them warm, and just watch them. 90% of the time, right? 90% of the time, we're just going to do that. The other 9% of the time, we're just going to maybe give them a couple breaths when they start breathing on their own, give them a little bit of blow-by, we're all good to go, we're fine, providing warmth, checking a sugar, like, we're good to go. The 1% of the time, when they're crashing, burning, things like that, then we're going to do PPV. We've got to ventilate those lungs, we've got to open things up, we've got to get that heart rate up, we've got to treat. So, NRP also does say, so a heart rate less than 60 is compressions for a baby, right? Anything less than 60 is compression rate, but you do not initiate compressions until you have given 30 to 45 seconds, full seconds of effective ventilation. Effective being the key word there. If you are bagging for a minute, if you're bagging this kid and you're not getting chest rise and they're not doing anything, you've got a leak on your mask, your whatever, like, we're not providing effective ventilation, right? So we're not going to use that as like, oh man, I've been doing this for 20 seconds, get ready to do compressions, our heart rate's still 50. We've got to get the mask focused on ventilation, get the mask sealed, get good position, I mean, a lot of times they're slippery because they're still gooey, like make sure their faces are nice and clean. Like, I think the most important thing with neonatal resuscitation is staying calm. Even though everything feels really hectic, you stay calm and focus on the baby. 30 seconds is really a long time, right? Like, think about when you're in a cone and stuff. It either feels like forever or feels like a blur, right? One of those two. But if you are focusing on getting effective ventilation and doing it for the full 30 seconds, chances that you'll have to do compressions on a baby are very minimal. Like I said, 12 years, we're not giving epi. And I mean, I worked in a delivery hospital where I worked at Utah Valley Hospital, which has the highest birth rate anyway. So we're going on probably average 10 deliveries a day. We're talking about babies that need NICU resuscitation. So they either have a risk factor that triggers the NICU, or they've come out and aren't breathing well and need some kind of intervention. I mean, they're the highest delivery hospital, like, in the state. So we're talking, as far as numbers go, like, we're cranking out a lot of numbers down there. And like I said, we're rarely ever doing compressions or doing epi. Rarely. And if we are, it's more likely to be a term baby than a preterm baby. So. And then, we want to aim for 40 to 60 breaths per minute. So 1 and 2 and 3. Breathe 2, 3, breathe 2, 3, breathe 2, 3. Right? We ventilate babies a lot faster. because they breathe a lot faster. Normal respiratory rate for a newborn is 30 to 60 times a minute. You know, so you see that on a kid or an adult, and you're like, oh. Yeah. But so like I said, so here's our little baby mask, right? This is kind of what you guys carry.
Mm-hmm.
Okay. Yeah. So just make sure you have good seal. Like I said, make sure you're going like covering the full mouth and nose. Make sure you have the right size mask. Do you just carry multiple sizes of baby masks?
No.
Infant,
Or like an infant and a okay.
adult.
So yeah. So better, like I said, a little too big than too small. You just want to make sure you're getting that full seal. So, and that's the most important thing. Make sure the mouth and the nose are both covered and that you've got that seal on. Is that a lot of times you'll start bagging, you're not getting effective chest rise, or you've got a leak, or because their faces are, you know, they have, you know, bigger cheeks, it's sometimes hard to get that seal. So holding the mask on right and getting that seal is the most important thing. So 30 seconds of effective ventilation. So with preterm babies, through your bag, if you have a blender, I'm guessing you guys are just straight 100%, right?
Sorry.
A blender, you don't carry blenders, right? Okay, then this is kind of a moot point. But just as we'll quick touch on it anyway. If you have a blender, because premature babies' eyes are so immature, oxygen is toxic to their eyes, and so we actually resuscitate preterm babies at 21% oxygen, and then we only go up like due to hypoxia after the 10-minute mark, like if they're not, and then we go up in like 5% increments, but we start at 21% and resuscitate 21%.
So when we're doing blow by, do we have to be concerned that we're putting 100% oxygen near their eyes, or since it's not?
I wouldn't be since it's most likely going to be short term, and right now we're just focusing on life-saving measures, not necessarily like, long term. Like, I wouldn't be so worried. I'd rather have my kid have blow by and not have a hypoxic injury than like worry about long-term eye damage. Yeah, it's more likely to cause damage long-term oxygen use, but we just start in the delivery room, like being conscious of that.
So 21% is just room air.
Mm-hmm.
So do you even hook it up to oxygen, or
Yeah, we hook it up to we hook it up, and then we have blenders on all of ours, so we hook it up and then just turn it to 21%. Because then if they don't, if we need oxygen, we use it up to whatever we need. But we initially start on 21%. We're usually just ventilating lungs, like I said, they've been statting like 40 to 50%, right? And so, like even room air is more than they've been getting in utero. And most of the time, they just need those lungs popped open. They just need like the pressure more than the oxygen. So, and so just make sure you're either using your smallest bag available, or that you're not like. That's the other thing adrenaline will do, right? Like crank that thing. But these babies' lungs are sometimes fragile too, and the more premature, usually. Or they're super stiff, and then once they open up, then you'll get like a whoosh, but you just don't want to cause a pneumothorax, which baby's bagging too hard or bagging with like an adult bag with a large tidal volume will give you a pneumo. Then you're in a whole different issue. I said any issues that we can avoid, hypoglycemia, cold stress, they have enough issues as it is. Like we're fighting an uphill battle as it is with these kids, so anything we can do to help ourselves out, let's do that. So you want to be getting chest rise, obviously, so bagging tight enough tidal volume so that you're getting good chest rise, but not enough to over inflate. So if you all you have is a big bag, just take the corner and just like pinch just the top. Don't bag it with your hand would be my recommendation, is to take it and bag it like this. So just to give a little bit of tidal volume but not overextend. So, yeah, this is a self-inflating bag. Just remember with the self-inflating bags, you can't give blow-by with them. You actually can use this part if you have to. Not optimal, but turn it around backwards. But since that's the oxygen reservoir, you can turn it around backwards and use that corrugated tubing like over and like you would with the camera. You just can't give flow on the patient outlet side, so you won't get good enough flow to give blow by. But if you don't have anything else in, all you have is a self-inflating bag, you can turn around and use the oxygen reservoir to give blowback.
A little bit.
That was similar to it.
Ours are just a tiny bit different.
Okay, okay. So, is everybody familiar with these bags and comfortable? Like, the oxygen just flows in and then you squeeze. Yeah. So, and then like the anesthesia bags, so these are oxygen reservoirs, self-inflating bags. You guys familiar with these bags too?
Yeah.
They're more like the anesthesia, they're just the anesthesia bags that like the oxygen reservoirs in there and then you squeeze it, so. Just, all I'd say is just be familiar with the equipment that you use. So, whatever you personally use, know how to use it, doesn't really matter. This is my personal favorite, like, resuscitator is the T-piece resuscitator. These are mostly seen in NICUs. Are you guys familiar with these ones at all?
No.
These are mostly NICU based, but they're the, if you see these, they're the T-piece resuscitators. Lifelight carries them and stuff, so if you see us using them, they're specifically for newborns. And they just hook into an oxygen outlet, and then you adjust the PEEP, like on that little blue knob at the top. You adjust your PEEP right here and your PIP right here, just on like a low, medium, or high set PEEP, and then your just readout is here. You just create a seal like this on your hand, and you bag like this. Like you include the PEEP valve to give pressure. So, and then your manometer reads out on that like actual dial. We'll give you so just in case you see them or somebody throws one at you, or, like if you pick up a kid in the ER, some of the ERs have those, and if you end up needing to bag, they'll send them with you and you can use those. And then once they're preset, then whatever, you hook them into 15 liters of O2, and then it's already set up on the dial, so it'll just stay at whatever you have it at. So obviously avoid pressure on the eyes and avoid pressure on the trachea. And then like I said, a good seal can be really difficult to obtain, so we just want to make sure that we always have a good seal. So are you guys familiar with the C to E position with bagging? Okay, so that's the best way for these babies on these tiny masks. Do a C around and then the E, put over the mask, secure your airway. Most newborns, you can just, it's good enough to just do it with one hand. You've got that position, but that will help you keep a tight seal, is keeping that nice C hold around that mask to hold that seal, and then the E position to stabilize the airway. So, questions on that? So, and then just make sure with that you're not accidentally, like, since they have like a small distance from here and here, that you're not grabbing their, like, accidentally putting pressure on their trachea. Sometimes when you're so focused on getting pressure on the bag, you don't realize you're using your fingers, like, kind of grabbing them, So, and then just watch for chest rise as you gently squeeze that bag. Like I said, I would recommend giving like a smaller tidal volume and then going up just to make sure that you're not over inflating and causing a pneumothorax.
Do you ever use MPAs or OPs on these babies or no?
Basically, like NICU, we use like back mask and so just know, like, if the chest isn't rising, it's most likely you, not the baby. I mean, newborns also very rarely have any kind of obstructive path, right? Like, what does that mean? Unless they have like a congenital issue, like a tracheal agenesis or something like that. It's usually you, not the baby, that's the issue. So just reapply the mask, reposition the head, increase your inflating pressure, give them a little more PEEP, help those lungs open up. Especially babies, if their water's been ruptured for a long time, those lungs can get stiff. If they're premature, those lungs are stiff because they're surfactant deficient. It's the protein that kind of helps pop those lungs open. They don't make as much of it premature, and so their lungs will be really stiff, and you might actually require more tidal volume than you might think to open their lungs up. So usually it's like, so the most common thing to happen with babies is initially they'll do fine, right? You dry, you stim, they start crying on their own. They, you might be providing a little bit of blow-by, and they're looking pretty good. And then you look at them, and they are or you are sitting there next to them and all of a sudden you start hearing grunting, right? So grunting is a physiologic response to babies trying to create back pressure into their lungs. That's them trying to naturally, physiologically create PEEP into their lungs, and that's the sound they make when they don't have enough PEEP. Their lungs aren't popped open enough, they're trying to get extra back pressure. They naturally do that. They start nasal flaring. You know, you've all seen the nasal flare. They retract. Subcostal retractions are the most common with like mild respiratory distress. If it's getting more significant, you'll see intercostal, you'll see substernal, subclavicular when we're like severe. But most commonly you'll just see, you can kind of see on this picture right here, this baby's retracting, that you can just see along the diaphragm that really just suck in. You guys all know what retractions look like. And then tachypnea. So breathing, we're talking 100, 120, 130 times a minute. Even with some of these kids, they'll breathe really, really fast. If you think their baseline's 30 to 60, like once they're getting above their physiologic baseline, like they're breathing really quickly. And so at that point, just know that you'll probably need to intervene. Like they're relatively stable, but we need to provide them a little extra support. So the best way to do that is if they're really significantly having distress and they're not able to maintain their sats and their breathing isn't regular, is just to continue with PPV. Just bag mask, seal them. Do you guys know where you start with PPV on a baby? Like what pressures you're using? So like standard pressure, like a good starting place, 25/5. Like just start 25/5, like for bagging.
Can you explain that?
Oh, if you're setting a PEEP. So do you just have PEEP and mid pressure?
We're not allowed to adjust if that's a filler still.
Oh, okay. Then never mind. Just bag till you get chest raised then.
We leave it at 5 millimeters.
For your PEEP, and you're not allowed to adjust.
That's kind of.
Unless the medic goes.
Yeah, it wasn't like.
Oh, okay. All right. Sorry, that's my bad.
No, you.
So yeah, literally you can provide PPV and just put the mask over and just give them enough to get that chest rise going and stuff. But if they're breathing on their own and they're just having a little bit of a hard time breathing, like 5 centimeters is about physiologic PEEP, right? But if they're grunting and having issues, they're not even creating a physiologic PEEP. So you can just hold the mask on their face with that PEEP at 5, and that gives CPAP, right? It just pushes that PEEP into their lungs. So if they're grunting, retracting, and the blow-by's still having significant distress with the blow-by, babies will hold for a long time in respiratory distress. As long as they're satting okay, and as long as they're not like sucking to their backbone and going apneic, like just provide the blow-by, be ready to bag if they go apneic, and otherwise you can just get them to where they need to go. But if they are going apneic and they're having, if they're breathing but they're looking like they're having significant respiratory distress, intercostal, subcostal, subclavicular retractions, you can put the mask on their face and just provide that extra PEEP that might just help step those lungs open a little better, make them more comfortable. So, yeah, keep providing the blow by O2. And then just remember, we want to decompress their stomach. So anytime you're bagging a baby, because their airways are so small, their stomachs fill up easily, they'll get bloated and distended, which then their stomachs push up on their diaphragm, which then increases their respiratory distress, which then, again, one of those things that we can do to make our lives easier, right? So just drop like an OG and Anderson, something like that. Usually it's an 8 to a 10 French. It's great. Orally is ideal, just because it fits in easier. The best way to measure, I think there's a slide on how to measure. Yeah, so an 8 French feeding tube or suction that will just help decompress that abdomen. So the best way to measure is just to go the nose to the earlobe, so measure here to here, and then down to the sternum. And then that's how far you can drop it. And you can do that like with the feeding tube. You can do that with a measuring tape. It doesn't really matter. You can do it with your fingers and then just like, yeah, it doesn't matter. So and then insert it through the mouth as desired, and then just make sure you're pulling back gently. If they look distended and you put it down and you pull back and you're not getting anything, pull back a little bit, because sometimes if you go in deep, or you go in and they get it gets stuck to the side of their stomach, like their stomach lining, and then you're just pulling against like their lining. But if you like pull back just a tiny bit, then it will. A lot of times you'll get like a whoosh of air. So, and then the best thing to do is just like tape it to their cheek or put like a tegaderm or something over it, just so you're not continually going in and out with it and causing like esophageal trauma. So I'm not showing just the right way to measure the tube. So, and then airway obstruction, like I said, just mostly like lining stuff up. We're not going to find like foreign obstruction and things like that. You may find congenital obstruction, like tracheal agenesis, like some kind of like tracheal stenosis, or something like that. It's just fluke things that you'll run into along the way. So, just warning signs that you're going to start getting into more and more trouble. Like I said, babies arrest because of respiratory compromise, not because of cardiac compromise. So, remember, babies have strong, healthy hearts. 99.9% of the time, if they arrest, it's because of ventilation issues, not because of a cardiac issue. So if they're not responding to the oxygen that we talked about, if they're getting blow-by and they're still having like severe respiratory distress, or they're still cyanotic, that's where we might want to provide that PEEP, or just go back to PPV, is great. Or if they start having like increased breathing and then start getting like a combo, like retracting, grunting, and flaring, hypoxic, tachypnic, and grunting. You know, a combination of them is a greater warning sign. Obviously, like additive, the more things you have going on, the chances are you're not doing well. And then periods of apnea, the kid's showing you like, I'm done. Like, if they start going apneic, just start bagging them and keep bagging them. Have a low tolerance for them. Like, if they start going apneic, you're like, all right, we're done with you. We're just gonna bag you the rest of the way. Basically. And then gasping, if they start gasping, it's a pre-cardiac arrest sign. So just know if you see a kid, a newborn that's gasping for air, they will not sustain that way very long. They just don't have the reserve to sustain for a super long time in severe respiratory distress. Mild to moderate respiratory distress, they can make it a long time. And if you give them a little bit of blow-by, like, they can compensate for a long time. But when they get to severe respiratory distress and they get so tired, once they start going apneic, like, they're basically just telling you they're done. Once they start going apneic, it's kind of downhill from there. So just PPV them and have a low tolerance for them once they start going apneic or start gasping. So, and then, like, last resort, if you're far way out, and last resort, intubate. And really, if you're giving effective PPV, you should be able to ventilate them just as well as if you were to intubate. If you have a good seal and you're effectively bagging, you know. I mean, what do we do when we miss an intubation? We just bag them back, right? You should be able to. And you guys go over intubation?
It's not our scope.
Okay.
It isn't it. I don't know. At least in our protocols, like for pre-hospital for us, we're not encouraged to. Not us, but the paramedics. They're not encouraged to intubate below a certain age, or is that?
Yeah,
still
they're
like
not. I think, and most of it, I think they're not comfortable. Like if it's not a skill that you do regularly, like neonatal.
Would cause more damage.
Neonatal intubation, every neonatal intubation is considered a difficult intubation just because of the narrowing of their airways. You know, most of like normal airways, like adult and pediatric airways, like kind of like go straight like that, and babies' airways funnel like until they get a little bit bigger, so they're naturally considered a difficult airway. Also, it's kind of tricky. Like I said, if you don't do it a lot, like just the technique of it is a little different than intubating like pediatric and adult airways, like, I mean, it's same technique as far as like lifting, as far as like, you don't have teeth, so that's nice, but you gotta stay off their gums or you can permanently damage their teeth. They're gonna come in. We don't generally, like, they RSI all peds and adults, right, for intubation. We don't do that for babies. And in the NICU a lot, like if they just need surfactant, we do unsedated intubations because we don't want to sedate them at all, because we put in the tube, we put in the medication, we take the tube out. So we want them to breathe, so we do unsedated intubations, which naturally then leaves you 40 weekers have the strongest tongues you'll ever see, like they'll tongue your blade, you know? And so it makes it, yeah, they're just not, yeah. And even sick babies, they go completely apneic, they close those vocal cords, and you just, you know, it's hard to get it. Like once they've gone apneic too, and they're in that stage, like, if you're not in a really controlled environment, with somebody who feels really comfortable with it, like you're kind of just setting yourself up for failure, you know? I think it is discouraged, like outside of a kind of NICU world to intubate. So, and because the equipment's so specialized too, a lot of people don't carry 00 Miller blades, you know? Very few agencies, because it's just such a niche population that you're not going to carry the equipment for it, so. And two, like we carry down to a 2.5 ET tube. Well, actually we carry a 2.0. But like our basic standard is like, if we can't fit a 2.5 in, we probably shouldn't be intubating. So. And like with premature babies and stuff too, you can do a lot of damage intubating. Their skin's so fragile and stuff. Even putting the blade in their mouth can like rip their skin and cause damage. So. But a good alternative to intubating is just like providing that PEEP, providing the blow-by, giving PPV, you know, if they're even, and like I said, even in severe respiratory distress, if they're completely apneic and they're gasping, if you're giving effective positive pressure ventilation, like you should be adequately ventilating them as well as you would if they were intubated, you know, with everything lined up and everything good. So an LMA is a good alternative too if you can't, if you have one available. I'll be honest, like we very rarely use LMAs in the NICU. I think I've seen one used once, and it was like for a congenital anomaly kid that was, you know, hard to get a tube in and stuff. They just don't work as well, and they're almost always unsuccessful with babies less than 34 weeks. But you can use it in babies that you don't know what else to do. Throw one down and see if it works. We've had kids that we didn't know had like tracheal agenesis, but they had like an air pocket or something that we can ventilate that, you know, we had no idea, but we were just trying stuff. And then, yeah, just positive pressure ventilation. So, and just remember, so this is for intubation, but it also applies with bagging. Just remember the small lung volume, so we're not blowing pneumos with them. And if you do decide to go to intubation, the most experienced person should be intubated. So that's just do it. So you become the most experienced? Yeah. Listen, I'm a procedure junkie myself, so I totally feel you on that one. I was like, I know you're more experienced, but why don't you just let me give it a go first?
They will never get experience.
Exactly. How do I become the most experienced? You're always
going to
doing.
become more experienced.
You're right. Yeah. You're like, we need to close the gap. Let's close the gap. I'm with you. Trip them, send them to go get something and intubate while they're gone. Lay all that stuff out and then step out of the room. But here is the basic like anatomical lab work. So babies also have like huge floppy like epiglottises that make it even more difficult for them to intubate too, because they just kind of flop over. Once you get the technique down, it's not too bad. But and also like esophageal intubation is really common because and so like on adults and stuff, right, their vocal cords are white. And the more premature the baby, the pinker the vocal cords are, so it's hard to identify exactly where the vocal cords are because they're pink and they kind of look like everything else. So if you're not familiar with what you're looking for, it can be a lot harder to identify what you're looking at. So basically, PPV is probably the best way to go. You can see kind of the visualized landmarks there. You can see how easy it is to miss and just go straight into the esophagus. It's pretty easy. So, and then babies naturally have more secretions and stuff too, so you'll get a lot of secretion blockage and stuff like that. Don't be afraid too, like when you are bagging giving PPV too, to come off every once in a while, and if they are having a lot of secretion, use that bulb syringe and suck out their mouth and nose and stuff. Be amazed how many secretions they can accumulate in a short amount of time. So yeah, esophageal cough is pretty common to happen, and then also right main stemming the bronchus, which then causes long-term issues with one lung being more ventilated and recruited than the other. And then, like we talked about with bagging, those tidal volumes, you get too high and their lungs will flow. So bag mask is just as effective if you're in good position and have good seal on your mask, and really should keep you out of the need to get to that point if you're doing it effectively. So some of the complications, like vocal cord injuries, if you use a tube that's too big, stuff like you can actually rip off like vocal cords and tracheal perforations or esophageal perforation. And then if you do end up intubating a neonate, just know that you hold the blade up and then we intubate from the side, not straight down.
Why's that?
To block, because their airways are so small that because you will a lot of times, unless you have like a super, super good view, which rarely happens, where all you have in your, all you can see is like the vocal cords and the trachea, you'll a lot of times have a crappy view where you're seeing like half esophagus, half, like you have like your upper half, you can see your cords and stuff. And if you go straight down the middle, you just completely blocked your view and any kind of manipulation with your hand and your tube. If you come in the side, you can keep eyesight with down your laryngoscope blade of like where your trachea exactly is, and you can actually see your tube go through the cords, and then you can turn it and manipulate it up. Also, if you're starting to go towards the esophagus and you can still see that, you can roll your tube over and it will naturally turn that bevel up and go in. So and then we tape on the face on the side like that. And just remember, if you're helping with an intubation or doing them, to never let go of the tube and to have like the closed loop communication with it. Like if someone asks you to hold their tube, you put your hand on it and you say, I have the tube, and then the person that's letting go should say, you have the tube, I'm letting go. Like just make sure you're very close with communication. It'll only take you losing one tube to get that down. Like super good. And just remember too, like with placing OGs, with doing bag mask seal, with like placing IVs and everything on this, these babies, like nothing sticks to them. Right, because they've been wet. There's a lot of premature babies, their skin's super fragile. Their skin will actually like kind of slough off, like it bruises really easy. It's really gelatinous kind of feeling. And so nothing sticks to them. So don't be afraid to use like some adhesive to stick it down, to like do an adhesive and then tape over it. Whatever you have to do to keep your equipment in place and stick it, like no one's gonna fall your lap. So yeah, so just remember your ABCs. You've got it. So remember, if your heart rate's down, you need to do 30 seconds of effective PPV before you move towards any other step. And then if after 30 seconds of effective PPV, effective being the key word there, of effective ventilation, your heart rate's still less than 60, at that point is when we initiate compressions. So if you have to go to chest compressions, right, which we're talking about less than 1% of infants here, so remember, we're going to dry and stimulate. This isn't scary because this is going to be less than 1%, and when you get here, you're going to be so prepared, it's not that big of a deal, right? So you're going to do chest compressions to be started whenever the heart rate remains less than 60 despite 30 seconds of PPV. So you have to be having effective ventilation in order to qualify for compressions. So people, we see it happen all the time. They come out, right, and it's scary. The heart rate's 40, and it's dropping and it freaks you out, people's natural tendency is to go right to CPR, right? Like, just remember, if you ventilate those lungs, your heart rate will most likely come up. And we can do more damage with CPR than with getting those lungs ventilated. So, but if you do have to go to CPR, you get 30 seconds of effective PPV, then go to CPR. You'll always want to do 2 provider CPR, if at all possible. 1/3 the diameter of the chest is your compression depth, and then a 3-to-1 chest compression to ventilation. So instead of breathe 2, 3, breathe 2, 3, it's 1 and 2 and 3 and down. Take a deep breath. You guys all breathe 2 deep breaths, deep breaths. And then you can switch to a 15-to-2 ratio if you think it's cardiac, but chances are it's probably not cardiac. So, and then you always use 100% during CPR. So the 2-thumb technique, and the encircle technique. So right, this technique versus this technique. Just always try. The encircle technique is.
That always seems so much more effective than the 2.
Yeah, I think the biggest thing about the encircling technique is you can feel how much of the chest diameter you're pushing, and your
circumferential.
What?
You're pushing from the front and the back.
Yeah, like you're getting a better squeeze. And I think like your recoil ends up better because when you're actually like squeezing someone's chest like that, right? It's not instinctual to like squeeze and hold. Where maybe like with this, sometimes you don't come all the way off. Like when you're squeezing, like you let go. So yeah. So the 2-finger technique is not really recommended anymore, but it works if you have to. And the best thing with 2-finger technique, if there are a ton of people around you, and there's somebody working on an IV over here, or trying to get an IO in down here, or trying to get an umbilical line in, and that's usually what it is. Somebody's trying to get an umbilical line in, somebody's bagging, and you come around hey, no, it's not. We're gonna just go back to that technique. But optimally, we'll do a circle technique. So
Typically pretty easy. Really tough.
yeah. Yeah, because they're fragile. I mean, they squeeze really easy, and because it's not like an adult where you have a ton of fat and a ton of that stuff to work through. Their chests are fairly compliant. They're little. They're easy to hold.
Do you hear the crunch that you do on adults?
So actually, their ribs are a lot more compliant too, because
flexible.
Yeah, they're a lot more flexible. So actually, breaking a rib when doing CPR on a newborn is not very common. Because they have a lot more cartilage, you can get away. They have a lot more compliance. Just everything's more compliant in a baby. They're a little more rubbery than adults, so you can get away with a little bit more. So it's actually uncommon to break a rib, and especially when you're doing that 2-finger too. Because you're kind of squeezing everything together. You're doing a whole chest squeeze, and not so much pressure straight.
We're all just old people.
Yeah, those old people, you just feel it break right underneath you. I once upon a time did old people, and that wasn't my gig. So, yeah, you can see the encircling technique, and that's the 2-finger technique. Are you guys all familiar and comfortable with this?
Yeah.
I'm sure you've done it a million times. So, if at all possible too, then do a 3-lead EKG. Just hook them up to that Zoll with the patches, and that's the best way. So you can see a waveform, kind of look for, get a better assessment a little bit there. And then also if you have a stat monitor and an EKG lead on too, you can kind of compare heart rates and your waveforms. So
You said sticking on the hand.
yep, right
Even
there.
with our ones that show the finger on it, that it should work.
Yeah, so I don't know if those are, I know if we always use sticky probe ones. Do you guys have the double pronged ones that you can put on each side? Or do you know? Because I've seen a lot of EMS people use those, and then just wrap probe it. The lights on each side, just put it on their hand, one on each
That
side.
should work.
It should work, yeah. Because there's not, there's not a lot of thickness here, and it's not a lot, that should work. and then just co-band, like around their hand. So, and if it's not working on their hand, try their wrist, like a light on each side on their wrist right here. So.
More effective, just more effective, what you're saying.
You'll get, so your pre-ductal sat, because of the physiological changes that happen in a baby, and because that PDA can still be open, and so you're getting some mixing with you're getting blood mixing before it's going out to the body. The right hand is a pre-ductal sat, so it's blood that's been oxygenated before it goes through that ductus and out to the body, so it's going to give you the most accurate sat of what's happening with their brain. So, and a lot of times, like I said, with feet, with acrocyanosis and stuff, they have such crappy perfusion to their feet, you'll get, low stat readings and stuff even when they're probably high. So just remember right hand. I just remember it because whatever hand you shake with. If you're, well, I guess if you're right-handed, maybe that doesn't work for everybody, but I was thinking that how I shake your hand is pre-ductal.
Choose the right.
Oh, that's a blood right. Choose the right.
That's it.
I'm just saying I never thought of that. I'm just saying. So, yeah. So even if you have an EKG on too, you should still have pulse oximetry on. It does not replace. You guys know that. Pulse oximetry. So, and then like evaluating for shock. So babies that have been required resuscitation are at high risk for shock, just like adults and peds and everybody else. So cap refill time, pallor, modeling, cool skin, bounding pulses, high heart rate. So tachycardia in a newborn, we're looking like heart rates of, so the smaller gestation, the higher the heart rate. You guys know that? So like a normal, so like a 25-weeker, it's normal for them to have heart rates in the 160s, 170s. 23-weekers, 160, 170 is a normal heart rate for us. You want to freak out a neo-nurse, take her into like an adult unit where everyone's heart rates are like 50 and 60, and you feel like you should do compressions on everyone. You want to freak out an adult nurse, bring them into the NICU where everyone's heart rate's like 150. And, but so we say like tachycardia, anything like above like 190s, 200s, tachycardic. So, and then the best thing to go by is just cap refill time, blood pressure, and if you're with them for a long time, like urine output. It's your best way to like really measure volume status. So obviously if their central cap refill time is more than 2 seconds, they could probably use a little tanking up. And so central and peripheral cap refill times, obviously your central cap refill times are going to be more accurate. If your kid's in a position where it's harder to see or access, like right here on the chest is a perfect place. On the forehead, extremities really aren't as reliable because their perfusion isn't as good. I mean, you can do a central versus peripheral to compare to see, if centrally you're doing better, then you're probably shunting more blood there, and maybe you're just still a little bit acrocyanotic, in the extremities, but centrally you want it 2 to 3. So, and then pulse checking. The best place to check pulses on babies is brachial and femoral. You'll get the best pulses there. And just make sure that they're equal, like I said, not bounding, and or not decreased. So, our goal is to improve cardiac output and to decrease the lactic acid buildup from anaerobic metabolism, and then just increase tissue perfusion and increase oxygenation. So epi, like I said, which is a drug, and NICU is super easy too, because we don't have a bunch of like, I'll tell you what was overwhelming when I took like ACLS. I was like, what are all these drugs in NICU? We're like, hey, let's give some fluid and let's give some epi, and that's like about all we do. Like, you guys have a hats off to adult people, because you do a lot more algorithms in your resuscitations. Like if they're consistently below 60 beats per minute after 30 seconds of effective PPV, it's inflating the lungs, moving the chest. If you do 60 seconds of chest compression coordinated with PPV using 100%, and you're still not getting a heart rate up. So you can see we're like doing all these steps, right? Trying not to use epi. That's why epi is like super uncommon use as far as like a resuscitation. We're talking, less than 1% of resuscitations, then go to epinephrine. So, IV or IO, or ET is fine too. If you have an endotracheal tube in, you can give it down the tube. So,
Ours is .01.
0.01. Do you have a 1 to 1,000 concentration? Is that right? Okay. Yeah, so I was just going to say that. A 1 to 1,000 concentration will be a 0.01, and then a 1 to 10,000 will be 0.1.
Our 1 to 10,000 is .01.
Yeah.
Yeah.
Just move the decimal.
Yeah,
Like,
it's our 1 to 10,000 is .01 milligrams.
yeah. Oh, you're 1 to
Or
10,000?
0.1 cc, 0.1 in 1 cc or 0.2 in 1 cc.
Oh, okay. We'll follow your guidelines then. NRP is 0.1 milligrams per, in the 0.1 milligrams per mil. So, and your dose, IV, 0.1 to 0.3 mils per kilo.
Probably bigger than you control that a lot better.
Yeah, probably. So, and then always with epi, rapid push, rapid flush. Every 3 to 5 minutes, as long as your heart rate remains less than 60. So, and in that time.
So I'm sorry, go back to that slide. The reason why it says that it's 1.1 milligram in 1 milliliter.
Yeah.
So that is that's the dose. Our dose is 0.01 milligrams per kilogram, but they're going based on a 10 kilogram kid on that. Am I wrong?
That what?
So that would be 0.1 milligrams per milliliter.
So that'd be a 10 kilogram.
Yeah, the concentration of it, and then the dose you're giving 0.1 mils per kilo. So the concentration versus the dose is different. So if you have a 1 to 10,000 concentration, you do 0.1 milligrams per mil.
We're doing for a 10 kilogram.
Yeah.
And then your
0.1
dose,
would
that
be
will be your
the-
concentration, then your dose will be 0.1 to 0.13 mils per kilo.
Okay, that's interesting, because the reason why is I was, one of my friends, his wife is a nurse,
Mm-hmm.
and she goes, well, you guys are not giving the right dose. I'm like, yeah, we are. Oh, we'll see what it's for NRP, but for us, we're gonna use the Rosal tape. But our standard dose is 0.01 milligrams per kilogram. We go with
Oh, okay.
and or whatever the Rosal tape says.
Okay,
Yeah,
so that's a little bit different than everything, because this is just per NRP, like the neonatal resuscitation guidelines. So,
Yeah.
and the resuscitation doses, so I guess ours is a little,
Yeah.
so per NRP
That's why only a
guidelines.
nurse can teach this class, actually.
Oh, really?
Just so you guys know.
So, well, so it's just a little bit different, I guess, but follow whatever your protocols and things say. This is NRP, like the National Resuscitation Guideline, but obviously then whatever, whatever your guideline is, follow your guideline. So the most, probably like the most useful thing though will be like volume expansion in a baby. So, because they're at such risk for blood loss and things like that, volume expansion really does help. When everything's kind of clamped down, they vasoconstrict. Blood volume just helps kind of open everything up, helps that blood pressure come up. So naturally helps them circulate better. So if they're not responding to the like initial steps of resuscitation and they have signs of shock, like that's a good time to give blood volume. So we give 10 mils per kilo is the an NRP guideline just of NS or O negative blood if there's like suspected abruption and the kid has a bleeding issue. We typically give volumes in syringes, not on bags, which starting to work with adult people, that was like a huge, like I was like, you just hung up a liter bag? We're like pulling out our syringes and pulling out. So that's a difference that is something to be aware of, that babies need volumes in. So if you have a 1 kilo kid, right, and you want to give 10 mils per kilo, just take your flush and give them a flush. Like we give volumes with flushes all the time. You know, even 3 kilo kids, we'll just give them 3 flushes and call it good. You know, they don't make it more complicated than it has to be. Just use what you have, and it's better though to push pull. If you have your bag and you want to pull off and push, then just clamp it, open it up, pull into a syringe, and then push into the baby.
Can we take 5 minute break?
Huh?
So it's measured better.
Just so that we have accurate measurements, because they're so small, and because, I mean, we do everything weight-based, right? And we don't wanna overdo it, we don't wanna, so you wanna give them enough volume to resuscitate them, but you don't wanna overload their heart to the point where you hit what's called like Stark's curve, which is where you give them so much fluid, so that heart just is stretched to capacity, and then they'll actually arrest when their heart's too stretched, like, you don't wanna hit that. The chances, I mean, it's super unlikely that you will, but especially if you don't know if they have a cardiac defect or something like that, it's just better to be safe and accurate. So.
Can we take 5?
Oh, yeah. Absolutely.
That was a good picture.
That was a great picture.
It's the cutest picture.
Right.
You sent a picture of me.
That's got a couple goals.
But if it's suspected heart, that's why you would.
I'm having a rough day, right?
For the reason, all the reasons why she's
Why do you have an eye?
like, that makes sense.
This is the video feature.
Oh, yeah. This is what I use.
Yeah. Why? Because, again, if it's a cardiac issue, they don't want to walk the heart, that's why they do. So if it's a cardiac issue, that's why we're talking about.
Yeah, they got a couple goals. That's funny.
So I just
I don't even know when's the normal spot.
Consistency is
pretty cool, huh?
is key.
I'm ready for more coffee.
Yes, in fact, I'm doing that right this second.
They have a Starbucks machine upstairs.
I'm gonna try this.
Yeah, it is
It
nice.
sucks.
And I think also they like to have like an LMS video to get trained up on how to use it.
Put this on stage, not
Starbucks
machine.
Barista.
Yeah, just recently. That's cool.
Makes sense.
I'm just gonna
I
mark
think
that.
What's that? I like that one, it's great.
No, we can't break it. It's firefighters.
Yeah.
Rural Idaho. People didn't like city slickers in rural Idaho.
Wait for me.
That's the other reason.
I was behaving like a gentleman.
So you didn't actually give them one more?
Yeah.
You just left her.
No, they was both ways. I didn't realize I was being in a bar fight. I was having a good time. Don't you know? Actually, those would be beautiful.
What you said?
Yeah, he was. We went to all the hospitals.
Oh, fun.
Yeah, it was fun. That's pretty fun. Completely not my fault.
What is the stuff they put in the baby's eyes when they're born? Is it an antibiotic or gel?
And it's erythromycin.
And then what do they do in the mouth? What do they squirt in that mouth?
When they what?
They squirt something in the mouth.
Not usually, like that, when they get their vaccines, like the rotavirus vaccine is like an oral. When they just get normal pediatric, like routine immunization. That's the only one I know of that's like a, we have like a glucose gel that sometimes if they're hypoglycemic, we'll do like a buccal gel,
It's still a very difficult thing, but like,
but not, that's anything routine.
Circumcision would give them
my
sugar.
70-year-old
Was that, I don't remember what they put in
Those
his
are my
mouth, but they
cousins.
said that would like take away his attention.
Oh, sucrose, Sweeties
Yours is
is
good.
probably what they get. So,
Hers is not.
they give like a really diluted, like sweet,
I don't know.
water, like basically sugar water. And what it does is it acts similarly on babies'
You are
brains to
not-
like morphine does on the same
Why?
chemical receptors. And so if a baby's distressed, you just give like put a pacifier in their mouth and like give them a few squirts of that, they'll suck on it and it calms them similar. It has an analgesic effect.
I just barely.
They'll do it like with circumcisions or like when they're like drawing blood or stuff like that. Like before we do a blood draw, like on a healthy non-emergent baby, we like give them a pacifier and give them Sweeties and then wait 2 to 3 minutes for it to have that like calming effect before we draw their blood. Decreases their pain sensitivity. Makes it acts like an analgesic.
I didn't know that.
Yeah.
Yes, actually, get John.
I'm not really gonna go like
Really quick.
West Hour. That's the
I don't know, look here.
weird.
When you get there. Oh, it's in medical. You know where the medical office is?
Yeah.
You never been there?
I don't come here that
Hannah,
often.
how's everything in Brooklyn?
Wait, this time it's raining.
Stupid. No, great.
Oh,
You wanna go?
You
hate
get up there
it.
and print some from up
I
there.
hate
It's like,
by
three or like.
hate
just trying to reference.
Yeah, no, he's
The
like,
super blow.
I don't know.
We're compliment. Yeah.
I don't know.
Comes from.
You don't know.
He just needs to build up here.
Someone drive.
Should we crack the rest of this out?
Yes.
We're all set. Let's see if we can get it done before.
Oh, yeah.
Let's crack it up. Let's get it done. Okay, so we've already gone over glucose. You guys feel good about that?
Yeah.
So
Yes.
vascular access, you need to start an IV. 24 gauge is what we use in neonates. And then just know, like, you're free to use basically any vein you can get your hands on. There's not a lot of restrictions in neonates. Like,
We have like a little light
Oh yeah, like the vein finder.
that do you use that
Mhm.
on the helicopter?
A ton, yeah. Like the neo glows or the whatever, yeah, like the purple lights or, yeah, they're super helpful.
Yeah.
Especially when you're looking at like bifurcations and directions,
Yeah.
they actually are. Just remember that when like they're under the light, go more shallow than you think it is. So
Okay.
the light sometimes is like misconceptually makes them look a little deeper, and their veins are really superficial. So remember that when you're starting on neos, is that their veins are really superficial. Other than like saphenous on really, you're not going to have to go very deep to hit a vein. And then you can do IO on newborns too, the tibial tuberosity or the femur. So we don't do humeral IOs. Just remember they're on neonates, yeah. Just remember their bones are soft and flexible, so IOs are less likely to work. But if you're in a pinch, you do what you got to do. So yeah, so you can see the neo glow there with like to find lights and starting the IV there. So yep, for blood, and then just make sure you secure it really well. Like I said, they don't stick very well a lot of the time. So and we also usually put a cotton ball under the hub of it because their skin is so fragile that those can cause divots and cause like ulcerative sores under the hub of IVs. So when you put it in, you just stick a little cotton ball under there, or a 4x4, a piece of a gauze, something, just to help alleviate that pressure from digging into their skin. So also, like, scalps are a great place to do IVs on a baby. No one likes the look of them, but there are actually less nerves in the head, so they actually hurt less in babies. And it's nice because you can swaddle their whole bodies and still have access to your IVs. Moms hate them. We love them. Like, just remember, if you're going to start an IV in the head, always go towards the eyes.
wait,
Yeah. Hope for that.
It's opposed.
right.
Yeah, don't start an IV this way.
Okay,
Always start it this way.
okay.
Yeah, just always go from the back of the head
Okay,
down.
because I know IVs always have to poke towards the heart, so I don't know which,
Yeah, so if you just remember on the scalp,
okay.
everything's going forward, so just always towards the eyes. Yeah, just don't ever poke this way, always go that way.
Why? What'll happen?
Oh, it's just the flow, it's not natural flow, then you're just infusing against natural flow, so. But yeah, feel free to like, use any vein that you would like on this baby. A lot of times hand veins and scalp veins are a lot easier to get than like ACs. I know you're probably all like super awesome at ACs. Hands are way easier. They're superficial. They're easy to see, like with the light and stuff. They're easy to hold, like because on a baby you can manipulate their hand a lot easier. You can singly like hold your pressure and start the IV all at the same time without a lot of issue. So, I kind of feel like we've covered a lot of this. So reasons for the babies will have cardiac arrest, we have already determined most of the time it's just ineffective ventilation. But other reasons that less than 1% that may have a cardiac arrest not related to ventilation will be things like abruption, sepsis, or cord accidents. So basically blood supply is getting cut off at some point, right? They're either bleeding out, they're being deprived of oxygen. That's prenatally. Postnatally, poor resuscitation, not ventilating the lungs. Severe hypothermia, because obviously the colder you get, the lower your heart rate's going to drop. Extreme prematurity, respiratory failure, and congenital heart disease. And then early infancy, the most common one we'll see is PDAs. babies get out of the hospital, their PDA is still open, and then they go home and it closes, and then they pass away. Or they code. Just remember when treating that we're gonna try stimulate, we're gonna just follow those initial steps of NRP with everything, and then treat the underlying causes. Remember to keep them warm, check their sugar, and get
Can I
them
ask
to
a question real quick on
Sure.
that one? So, why have we pulled away from using a sodium bicarb? And the only reason why I say this is because I was on a full arrest on pediatric, and pals have said not to use it anymore.
Yeah, we don't use it in the NICU very often either.
And so we've worked this baby for almost an hour, and another air ambulance landed. Another air ambulance landed, and when we got there, her doc said, "Let's go ahead and give sodium bicarb." Well, we hadn't had a good heartbeat forever. He gave the sodium bicarb, fully came back alive.
Really?
And
Sometimes you probably don't want them to come back alive.
No, we didn't. No, that was my issue because we again worked for an hour.
And I'd say a lot of times what you'll see is you'll see a short term, like, better, and then you'll see
And then put them on a drip
deterioration
and then
again.
die.
Yeah. And really that's the main reason we don't use bicarb as much. Like when I started in the NICU, every morning we'd get blood gases, and if they had a deficit greater than 5, we gave bicarb as a volume every morning. You'd see a lineup of nurses at the AccuDose waiting for bicarb every morning. We used to give it standard to like everybody for deficits to help with any kind of metabolic acidosis and things like that. But what they were finding with it mostly is that we're fixing the numbers, but we're not actually fixing the problem.
Okay.
Right? Like you're still going to be acidotic, and you may just recruit and kind of rally a little bit and fix your numbers short term, but will short term fix things and not really ever.
Yeah, that's exactly what it was. It was a rally.
Yeah,
Enough
it's kind
to
of a
just
rally,
like
and a lot of times
primaries.
we're just like we're just prolonging when we probably shouldn't be.
Yeah.
Or, so if in extreme cases we'll still use it as kind of like a last ditch, or like as a we need a temporary rally until we know we're getting somewhere else for an end game, right? But as a standard dose, it's
All right, thank you.
just
Sorry
not
for
that useful.
interrupting.
Oh, you're good.
Okay.
Totally good. So, so just during resuscitation, we want to try to keep all of our vitals with our resuscitation as normal as possible. So respiratory rate 40 to 60, heart rate 120 to 160, and then just colors, checking that central cap refill time, giving fluid as needed. If you are effectively resuscitating and the patient is responding, you should see appropriate responses in resuscitation, heart rate, and color should be improving. So, and then just post-arrest, if you get them back, then just continue where you're going to the NICU, continue to monitor vitals. Are you guys familiar with APGARs? Do we need to? Okay, I'm going to skip over APGARs then, okay? I feel like we've covered most of that. So just remember with extreme premature low birth weight babies, keep them warm, sit in that plastic and stuff like that. And then also just remember that their capillaries are really fragile, and giving anything too fast can burst those capillaries and cause brain bleeds, which can cause long-term detrimental neurologic effects. If you guys go on a home delivery or something and pick up a baby that's premature, you can really have a huge effect on their long-term outcomes based on what you do in that in that initial resuscitation phase. Because we can't fix brain bleeding. Sometimes the bleeding reabsorbs a little bit, but we can't fix it. With little tiny babies, just remember everything like slow and steady, and then if at all possible to always keep their heads midline. Because you don't want to just think about physiology when you're treating these kids. You don't want to kink off any kind of blood flow. They're real tiny vessels. You don't want to kink up any blood flow, and then you turn their head and all of a sudden they get a whoosh of blood flow. Don't break those vessels, cause bleeding and stuff.
What's NPO in the post-arrest management?
Oh, nothing by mouth.
Nothing by mouth?
Yeah, so just no feeding them. Yeah, thanks for clarifying that. So So we just want to keep their environment like as stable as possible and just slow and steady with them. So, okay, so let's go over. So, normal neonatal circulation. Here's normal neonatal circulation. Okay, everybody familiar with this? This is just normal circulation, right? So shunting in babies, which is where we get issues, is when this PDA at the bottom. So you know when babies are born, you guys are familiar with neonatal physiology, when they have two holes, we're bypassing the lungs, right, in utero. And so they have this PDA, which is patent ductus arteriosus, so there's blood flowing through there, and then the foramen ovale, so the right atrium and the left atrium, there's blood flowing through there, and then there's blood flowing through the pulmonary, between the pulmonary artery and the aorta. And then when baby comes out and takes their first breath in order to increase vascular systemic resistance, pulmonary vascular resistance, this shuts off, right, to increase your pulmonary aortic resistance to get blood to flow to the lungs. And then the foramen ovale shuts off to make everything flow right. Does that make sense? So basically to get blood to shunt to the lungs where that hasn't been previously used. That's the change in physiology in a nutshell. Well, a lot of times babies, it's not uncommon for babies to have their PDA open for at least 24 hours. A lot of times it closes slowly. It doesn't always necessarily just snap shut right as soon, which is what they think with the delayed cord clapping, and sometimes helps with that too. Like I said, that slower transition rather than expecting it to just all kind of snap and go automatically. But if that remains open, which is not uncommon, then you'll have blood mixing between the two sides, because you'll have some of that pressure obviously coming off over to the aorta and having non-oxygenated blood going out to the body, which is the reason that we want to always use that preductal sat. So this makes a little more sense in the picture. Maybe it's easier to see what I'm talking about with that preductal sat. So if you see your pulmonary artery that's going up to your lungs, right? So the physiology of the heart, it comes in, it's going down, and then it's going to the lungs, and then back, and then the aorta out to the body. So the preductal sat is the sat that we're getting before the most oxygen-rich blood. Does that make sense?
So it's connecting the pulmonary artery directly to the aorta, the PDA is?
It just basically, it's a hole. It's not like connecting directly, but it's just, it's like leaving open flow between them. And when normally, in like ideal physiology, that's closed. So you're just having blood mixing, basically what you're having. So
That's pretty cool. I didn't even know that was a thing.
and then this is just a right to left check, which causes. So it's normally not a problem unless you have a coarctation, which is where that aorta is stenosed, and so you're having a hard time getting oxygenated blood out to the body. If you guys want a really good heart app, then download the Cincinnati Children's Heart App, and it goes through like all of the different heart physiologies and stuff. It's really cool. But just know, if they have a PDA and they have a coarc, they are dependent on that duct for mixing and circulation, because it's giving them, it's allowing them like kind of a channel to flow through before it's flowing out. If they're stenosed in that area, they're not able to push, then closing off that PDA shuts off their oxygen supply. If you see a baby come in like 7 to 10 days, this did just great delivery, uncomplicated, and is all of a sudden having either an arrest event or severe distress, then you should be like thinking ding ding heart kid, and please prostaglandins to open that duct back up. It's just a ductal dependent heart anomaly. So just think about it. If like instead of treating with CPR, and you'll treat with CPR, but instead of focusing on other things, focus on getting them to a facility where they can treat a heart defect. That makes sense.
So primary.
But, yeah, primaries, or even just to an ER where they can get prostaglandins. So, it's just basically time is of the essence for those kids, so just realize that time is the most important thing, and the best thing you can do is just get them to a facility where they can get the medication, because that's the only thing that's gonna help them. Oh, and that's just Pierre Robin. So these kids are just extra. If you see a kid come out that has like an extra small jaw, it's a like fairly uncommon neo-anomaly called Pierre Robin, and it just their jaws are recessed. It makes them really difficult to bag and hold on those kids. If just make sure like you're doing like your E position, holding extra chin support and stuff there, because your mask will be, you know, further like down and recessed. It's just harder to get a seal on them. These kids also too usually do really well on their stomachs. So if you have a kid that you see has a really recessed jaw and is having some respiratory distress, if you're transporting them, flip them on their side of their stomach. It's easier for them to breathe, just offloading some of that pressure where that jaw is recessed. So, and it's not uncommon for them to have other anomalies, cleft lip and palate. You don't need to go over diaphragmatic hernia. Diaphragmatic hernia is where like the diaphragm was either weak or ended up with a hole in it, and the bowel comes up into the chest cavity. So, sepsis is super common in newborns. Most of it's idiopathic, and we never find out exactly where the source of the sepsis came from. Group B strep. I'm sure you covered in your OB class. They check Group B strep on all pregnant women. Like 10 to 30% of women are carriers for Group B strep. If they get treated with antibiotics prior to delivery, they usually do just fine. But it's the same thing if you have a kid that's gone home and comes back like 24 hours later, just not quite looking right. Usually not close, like 2 to 3 days out. It's usually Group B strep sepsis can be a late onset sepsis. Like they'll look fine for about 24 hours and then they'll just kind of start to decompensate. If somebody doesn't pick up on that decompensation, they can get into a lot of trouble and get really septic before people pick up on it, especially when it's been a healthy newborn that's been eating great and doing good, you know. So, talking about risk factors for sepsis. Bradycardia. So just evaluating the ABCs, the heart rate should always be above 80. The airway pain, is baby breathing? Are they pink? Are pulses palpable? And how's the perfusion doing? So like we talked about before, usually bradycardia is caused by hypoventilation more than any kind of cardiac issue, so just ventilate and we got it. So it's really rare for a newborn to ever have a fever, so don't expect to ever see a fever even in a really septic newborn. The only time we ever, more often than not, if we see a fever in a newborn, it's usually viral related. It's more often than not when the mom had herpes and we need to treat for a viral infection more than a bacterial infection. So just keep that on your radar, but make sure that it's, but just know that it's super rare. They can be really septic and you'll never see a fever in a baby or whatever. Temperature instability is more common, where they get cold rather than hot, or they'll kind of fluctuate normal to cold, and then just be suspicious of meningitis and dehydration. So,
just going with the getting that from their mom. How common is it? Because you should probably know this more about OB stuff, but for a mom to give the baby like certain diseases, like you mentioned herpes or HIV, or like different blood hepatitis per se, like what are the chances or the rates that the baby gets what the mom has?
Yeah, I don't know what the percentage is on that. I do know like if mom has like active like STDs and stuff, like an active herpes outbreak or things like that, that they'll do C-sections to decrease the risk of that, because we're talking like mouth to membrane, you know, like exposure. I don't know what the percentage is as far as like bloodborne pathogens and stuff like that, but it's also one of the reasons that they give erythromycin eye ointment to all newborn babies as a precaution. The antibiotic ointment in the eye is for that, for any kind of bacteria and stuff that they may get as they're born. like just to decrease that risk of contamination. So yeah, and I don't know what the percentages are on that of it. So yeah, and most of the time, if babies are like stable, healthy newborns, you don't have to worry about their temperature. So seizures, like I said before, like seizing can be like SSRIs, it can be hypoglycemia, it can be hypernatremia, hyponatremia, hypocalcemia, or like brain disorders, hypoxic events, and things like that. Basically, it's really hard to identify what's causing a seizure in a baby, so the best thing we can just do is treat. And babies a lot of times will have seizure activity too, but because they're not doing a lot more than like eating and sleeping, sometimes it's hard to pick up on seizures, especially if they're not like a tonic-clonic seizure, if they're just like a subtle seizure. That, you know, because I've seen a baby that had like a sucking seizure, and so like every time he'd have a seizure, he'd start sucking. Well, that's normal behavior in a baby, right? Until you realize it's rhythmic, it's infrequent, and when he's doing it, there's like other issues associated with it. So just be aware they may not have like a typical tonic-clonic seizure. It may be more subtle. So, but just make sure their airway is clear and established, that you're giving oxygen. Like I said, blood glucose levels can cause seizures, and that you're keeping them warm.
They'll drop their stats during their seizure too, right?
Most of the time, yeah.
I just had one that did that.
Yeah, most of the time they will. So, and then we're not gonna go over, well, okay, so we'll touch quick on vomiting. So any kind of colored vomit in a newborn is considered like, bilious emesis is considered a medical emergency in a newborn. So just know, like, green bile vomit is never normal. If anyone says, hey, my kid's throwing up green in a newborn, they need to go to the hospital immediately. It seems benign, babies throw up all the time, but bilious emesis is never normal. And bowel issues can progress really quickly and be deadly. So, if they're vomiting, you just want to know if they're protecting their airway, the amount of the color, and if it's projectile or not. Projectile vomit's more specific to like pyloric stenosis, but have like a narrowing and it causes the projection. But so you just want to get them to the closest facility as quick as you can, so they can be evaluated and rule out what's going on, and then where they can get them to interventional radiology and do upper GIs and things and make sure it's not a volvulus or a malrotation. But the best thing that you can do is just keep that stomach empty with the OG, keep aspirating out anything in the stomach, support their respiratory status, and provide IV fluids and fluid boluses to treat shock and keep their glucose stable. So, and then diarrhea, let's get real, like diarrhea in neonate is like super uncommon, and they have like loose watery stools anyway, is like normal for a baby. So anyway, just if they're, you guys know what diarrhea looks like, and the biggest thing is like just protecting to make sure that they're not getting dehydrated and that they're
Is that the same with, the treatment of that?
So just be like IV boluses, electrolyte replacement, just monitoring that, yeah. So yeah, just monitoring for dehydration mostly. So if they're getting tachycardic, if their urine output's low, their fontanelles are sunken in because they're getting dehydrated, they're really lethargic, or they're having blood in their stools, they need to be evaluated for, further evaluated for dehydration, and intervention needs to happen with that. So with that, with diarrhea, NS or LR 10 per kilo. And the same thing with the boluses, like with resuscitation, they're on a syringe, so we can be most accurate. And then birth injuries, we talked about this a little bit in the delivery part. Like if a baby has had, like we said, maternal history is really important in neonatal resuscitation. And part of that is knowing, like, if there were forceps used, if there was a vacuum used, if it was a complicated delivery, if they were stuck, if they had, an abruption, clavicle fractures, anything like that, just because those are things that we'll want to look for. So with vacuums and forceps, they're at higher risk for like hematomas, they're at higher risk for subgaleal bleeding, and if you suspect that, then we just need to keep passing that information on so that the NICUs can accurately record and monitor those things. So actually with subgaleal bleeds, have like 25% of babies that get subgaleal bleeds die. It's like a really high percentage for that complication. So yeah, best thing for transport is just support the airway, provide PPV and keep that airway open, get IV access, give IV fluid if needed, check that glucose, keep them warm. So then the most appropriate receiving, maybe this will help clarify some of that. The nearest facility, you can request, just like on accident scenes and stuff like that, that Lifelight come to newborn scenes. We've actually done a couple scenes like on the side of the road, babies that were born like on the side of the road, or we had one that was born like up in the mountains. The mom was camping, claimed she didn't know she was pregnant, had a baby like in the bushes. Like,
She didn't know.
she said she didn't know.
Is she water injured
It's
or
possible
like?
to not.
There really are people that legit, I guess, don't know. So
But how?
I don't know. What? You said it's bad.
That's what they usually bad.
So it turned out this mom was like 19, and it turned out suspected she was pregnant, but didn't want to tell her dad. Had no idea how far along she really might be, suspected she might be pregnant, and then had a baby. But while they were out elk hunting,
That's so weird to me.
So I just remember in those like less than optimal conditions too, like scenes and things like that, to make sure they're staying warm because we're out in the elements or anything like that. Ambulances, side of the roads, back of a car, anything like that. So, all right. So let's see what you guys have learned. Right? This means we're almost done. We're almost there. So 38-week gestation, and able to get to the hospital. Baby's crowning. Just arrived and the head's being delivered. Who's gonna go? What are you guys gonna do?
Catch it. Having a baby.
Yeah, catch this baby. And?
BSI, my CNC.
Okay.
Hold pressure on the head.
Okay.
Gently guide it
Okay. That was good catching position, actually.
What was that one more time?
Down set.
So I,
Yeah, exactly. Okay, good. So baby's out.
Look for flat scores, so.
Okay, so now baby's out. Now what are you going to do to resuscitate this baby?
Do what seems simple.
You know what?
Stimulate it. Do what seems simple.
Yep.
Was one of the acronyms they gave us.
Dry.
So
Suction the mouth and
dry,
nose.
suction,
Provides stimulation. Said this is in the 90%, right? So it was less than optimal, but this falls into that 90% where just because we're there doesn't mean it's going to be a big hoopla. Most of the babies are born, you got them, they're safe, they just need dry and stimulate, they're good to go. Evaluate respirations, evaluate circulation, and okay, we've got a home delivery now, a little less than optimal, right? 10 minutes of age, baby's blue and not breathing. The dad's doing mouth to mouth when you walk in.
Ventilated
for 60 seconds.
Okay, 30 seconds?
30 seconds.
Yep. So they're doing that. What are you going to do?
Wrap them up. Keep them warm.
Stimulate them? You've got a blue baby though, it's not breathing. Start PPV.
Suction.
Yep, suction and start PPV.
Get a heart rate.
Okay. Yep, evaluate heart rate and then progress with your steps of NRP. So provide PPV and then evaluate for spontaneous breathing and a heart rate. What does the heart rate, if you provide 30 seconds of effective PPV and what does your heart rate have to be?
Above 60.
Say above 60. If you're still below 60 after effective ventilation, then start CPR. If it's above 60 after effective ventilation, keep doing PPV. Yep. So just get to the hospital and consider rendezvous with specialty teams if that's appropriate. So 5-day-old baby at a clinic that's blue and showing signs of respiratory distress. Okay, has a history of doing well at home until today. Discharge, has been just fine at home. Mom started noticing the baby getting a little cyanotic today, came into the pediatrician's office.
What about
Ventilator.
Oxygen.
Okay, get some
Suspect
oxygen.
sepsis.
Suspect sepsis, and what else are you gonna suspect? Heart, a heart defect, okay? So any baby that's gone home, that's then coming back with like signs of respiratory distress that has been previously healthy, sepsis, and cardiac defects are what you're gonna automatically kind of go to with this less than 30-day population, right? And neonate is 0 days to 30 days. So in this population, high suspicion of sepsis, high suspicion of cardiac defects if they were born healthy and have gone home, okay? So perfect, yep. So provide ventilation for apnea. Think about cardiac, get them to a facility where they can get prostaglandins. Okay, so now you got your 22-weeker. And delivered at home. On arrival, the baby's teeny tiny and blue, but breathing.
Stimulation, PPV.
You're providing supportive care, but they're not viable.
Yeah. So, yeah, remember the basics. Provide warmth. Get them to the hospital depending on the location. If the baby is breathing and you can reasonably provide care, we should continue on with care, right? Like that's not our decision to make at that point. If the baby's breathing and things, chances are they're not viable, we won't continue, to be able, but providing PPV, providing warmth, support, basically do what you can do on this one, right? Okay, so this is actually a baby that we transported. So this baby was born at home, 22 weeks. Mom said she didn't have a lot of labor contractions or anything, was just hanging out, and all of a sudden baby was out, right? So they called Lifeline for a scene flight. EMS had got there, dried and stimulated the baby, and they had called, so Lifeline rendezvoused with them. They passed off to us. They were able to intubate. Mom said she was 22 weeks gestation, but the baby was blue and breathing. They'd given, like I said, EMS had given PPV and passed off to Lifeline. They intubated and took the baby to a NICU. You can see the umbilical lines they placed. This is what you can see, how the skin's gelatinous, kind of see-through. Their eyes are fused shut. You can see how big he is compared to that
That's crazy.
mom's hand. But teeny tiny, did pretty well once they got into the NICU. You can see he got a little bit septic. You can kind of see his skin. It's not uncommon for these babies to struggle with hemodynamic stability and infections and gut problems and some stuff like that, but did fairly well with that. Was in the NICU for 6 months, but continued doing well. 22 weeks gestation. Getting a little bigger, we're in the 30s there. He's just about term, getting ready to go home. Started eating, but still required a little bit of oxygen, not uncommon. A lot of babies go home on oxygen. Finally was able to go home after 6 months in the NICU. There's him and his mama though. And he did really well. Does have some delay, some Asperger type issues, but he overall that's him on the right hand side. That's his older brother, and that's his baby brother. That's bigger than him now, but you can see but it really is. It's those first responders that got there very first, that made those initial steps, that made the call to get this baby the help that they needed, to get to get the right people there, to get them where they needed, that started the PPV, that dried and stemmed, that got him going, that really, makes the difference. Those first times are, that first encounter, like I said, as far as you have the ability to change long-term effects in that short term that you're with these patients. So what you do is appreciated, and it's a hard job, so keep it up. That's all I got.
Thank you.
9 minutes early, come on.
That's it?
I mean, I can make up some more stuff if you want. Should we do it again? Anyway, any questions, concerns, anything I can answer? Or? Okay, you guys were great. Thanks for being a great group and being interactive and asking questions. You were great.
Thanks for coming and teaching.
Yeah.
Thank you.
Sorry, I kept stealing students.
That's all right. That's all good. I gave him a good break.
He's like, we'll take me water bottle.
Don't worry, guys. I'm officially in the class.
Were you not before?
No.
Shows up, good lawyer.
Parsman.
Oh my gosh, that is such a pain.
Oh, that's right.
You always bring
You get done early, throw some skills out.
all you
And then you can call me and my old man, and we up there with you.
So Thursday, we have incident command, or incident management. Incident management. Chief Watkins is the so this is kind of his bag. He loves so he may take the whole 4 hours. If he doesn't, we'll do some skills after he gets
Wait, that's
done.
next time?
So, Thursday. Okay, any questions? You got all your problems taken care of today, I hope? Taryn?
Yes, I'm accepted, I confessed.
I'm
too.
worried about the two of you. Are you guys going fishing again?
No.
Yeah, they're really acting up.
What happened last night?
Oh, we taught friendship.
Their first date went well.
Taken care of, she's gonna.
Okay, Kylie?
Yeah.
I'm not going to make sure that's going to happen and everything.
Okay, Kylie, if you need help, I know how to do it. I just did it.
Either way, I know you think
I'm
I'm idiot, but
having a rough day.
you send me a text or something, don't forget. Okay, and I'll just keep bugging my
I don't understand the like.
Can I get out or someone have to let me know?
No, I didn't get out. I'll walk out.
30th we know it's test, right? But any other days that I need to.
We are doing, so after tomorrow, we are doing nothing but skills. And you guys memorize those skills that haven't done down in basically 2 weeks we're done. So skills. So what I want you guys to do is just print out those things and memorize them like fire one, fire six. Do them at the station, do them wherever you can do them at to try and knock one out. Not like the one thing is IV and IO are almost identical, but you have to do the IV and then go give the drug. Make sure you guys remember your doses for 50 Narcan, possibly Hep B, possibly Atropine, but usually it's one of those two first.
Chief, did you as some citizens that would like to? No, after you see them, I couldn't think you that well. I had to go way west if I'm in the middle of that. I don't want that. I'm just trying to do some things.
So I'm good to go, I don't need to.
You're good to go. And you are now hooked up. Days, second or first or second of May. I'll send it out. Okay.
I'm scared.
Yes.
Wait,
I don't have to do time.
oh, it's open until 3:30 today.
Okay, sorry.
You already have it assigned?
Yeah. Okay. I'll do it now.
Okay. If there isn't, talk to Dan or I, and we'll open up for another day.
Okay. Have you?
Well, I did it, the whole thing with whatever her name is.
Yeah. You want to help me do it?
Sure.
Okay. I thought it seems exciting.